complete lab, Module D. It goes through open catheter first. So we'll go with open catheter first. It's got a whole bunch of pre-reading, and then you're going to go through what are you looking for in the way of your kind of ABCDE, airway, breathing, circulation. Those are the types of things you're going to assess first. So I'll let you read those when you have time. Wash your hands, introduce yourself to your patient. Even if they are sedated, maybe unconscious, you're still going to tell them who you are and what you're going to be doing. And then gather all the equipment. Okay, so we're going to say we've got oxygen flow meter on the wall. We've got a bagger. That's part of our safety equipment at every bedside is a bagger, masks. Okay, even if the patient is intubated, all that equipment would be beside the bed anyway. Okay, bagger's always hooked up to oxygen, ready to go. Okay, in this case, because our patient is intubated, we have our bagger. It would be hooked to oxygen, and on it I've got a piece of flex tube adapter and a swivel connector. Okay, so that way I'm not bagging him like this. Got a little bit of flex on it so that we're not pulling on the endotracheal tube once we take him off the ventilator. Okay, this particular adapter is called a PEEP keep. Okay, so with using open catheter, the problem with it is when you have to disconnect the patient from the ventilator every time you go to use it. Okay, so we could either have a PEEP keep on the ventilator circuit, on the actual adapter itself, or have that on our bagger. So this bagger would have PEEP on it as well. So it'd have a PEEP valve on it. Let's say the patient's on 5 PEEP, set it to 5, and when I disconnect the patient from the ventilator and start bagging him, he'll still have 5 of PEEP. Okay. Now when I want to suction, every time we pull this off, I'm breaking the PEEP, right? That everything starts to deflate, alveoli collapse on themselves again, and then when I put the bagger back on, I've got to reinflate the alveoli, and it's really detrimental to the patient to have to do that every single time. Okay, so this PEEP keep adapter, let go of the bagger. Okay. On the end of it, when you pull off the cover, it's got a little one-way valve on it. Okay, and when you put the suction catheter through there, it blocks it so that you're still maintaining the PEEP in the system, hence PEEP keep. Okay? That's why it's called that. So that's your PEEP keep adapter. Okay, so if you are bagging a patient who is supposed to be on PEEP, this would be the best adapter to use for that. Okay. So if someone is bagging my patient for me while I'm getting my other goodies together so that I can suction the patient. Okay, I'm going to put some saline in here. My magic sink of normal saline. Okay, got a syringe and I'm going to fill it with some saline. Okay, I'm going to put my sputum trap here as well because I'm going to have to take a sample from this patient. I've got my suction ready to go. I'm going to use a suction catheter. This one's a 14. Yeah. Okay, it's different sizes, and when you go through your lab in class and stuff, we'll talk about sizes and what size you should use. Okay, so it's sterile when we're going down the endotracheal tube. Okay, it's called a sterile technique. Not so sterile when you're using tracheostomy tubes on the floors, especially. Okay, once they're on the floor, they've already been exposed to everything. They may be breathing spontaneously. And when we suction them, we just need to keep it a clean procedure. But if we have a patient that's intubated on a ventilator, it's a sterile procedure. Okay, so we have to maintain sterility of everything. And this is the hardest part of your lab, is maintaining sterility. Okay. I remember the first time I ever suctioned a patient in real life. It was in Kelowna. The patient was on a ventilator. And my preceptor said, okay, get your suction stuff ready. We have to suction this patient because there's secretions coming out, his endotracheal tube everywhere. So he needed it like desperately. And we didn't have closed systems back then. Okay, so I'm getting all my stuff ready and I broke sterility. He says, nope, put it all in the garbage, start again. I did that 12 times. Yeah. We didn't practice this in the lab. So now it's hard. start a new practice. Hopefully you'll get it straight before you get out of here. Okay? That's the hope. Okay, so I need a catheter. What else do I need? If I'm going to try to maintain sterility.
Gloves and sterile gloves as
Yes,
well?
you bet. So I've got clean gloves. I've washed my hands already, and I've got a sterile glove. So just one glove. Okay. So I'm going to open this up. So this is a medium glove. You could use one size larger than what your clean gloves are if you want, if it's easier for you. Okay. I would also put on my PPE in case I get sprayed. Okay, so we're still oxygenating the patient. I am going to get my suction set up. Okay, suction catheter. So suction catheter is going to stay in the package, and I'm just going to open up the end where the connection is. Okay, this part is going to be clean. It's never going to be sterile because I'm going to be touching it. Okay, and I'm going to connect it up to my suction tubing. Stays in the package. Set my suction to regulated. A regulated suction is 100 to 150. Okay, occluded. So you have to occlude it first. Right now, about 120, which should be plenty. Okay. Okay. So I know that's what we're set to.
Do you ever look at the thickness of the secretions and go, ooh, that's a 150?
Oh yeah.
Yeah.
It's usually after first pass though.
Okay.
So we do one pass first and have a look at the secretions. How thick are they? How much is there? Does this patient need instilled? So those are all the questions you would ask after first pass. If you notice they're really thick, tenacious, then yeah, you may have to increase your suction pressure. Absolutely.
And we can go over 150 if that were the case?
150 is usually the maximum.
Okay.
If you're going over 150, then you're exposing the patient to that negative pressure within the lungs itself.
Yeah.
So look at your risk benefit again. If I do this just once, then it might be okay if I can get the secretions out. Okay. There's other ways to deal with the thick secretions though, by putting some normal saline down there and hopefully watering them up a little bit so that they're easier to suction. Okay, so we got our suction on. I'm just trying to think what else I'm gonna use here. So I've got normal saline here as well. Okay, like I said, someone is still bagging my patient up. So which hand you put your sterile glove on, it's entirely up to you. Okay, which one you would like to use. Okay, I tend to use my left hand for keeping sterile. Try it both ways, see which one works better for you. Okay, so now I can't touch anything with this other than the end of the catheter. Okay, so don't be picking your nose at this stage. Okay. All right, I just stick it under my arm and pull. Okay, so I can touch the catheter. This part I can touch the control. So I'm just pulling it, I'm just controlling it so it doesn't flop out and do this all over the place, okay? So you just try to control it. See my fingers, it's not gonna go anywhere. We're just gonna keep these because we're just gonna reuse them. Okay, don't do that in the hospital. Okay, I'm just gonna dip this in the normal saline and make sure, yeah, it's working. Okay, I've got suction. Okay, now we can suction the patient. So we'd look at heart rate, look at their cardiac rhythm, look at their blood pressure, look at their saturations, make sure everything is okay before we disconnect or use keep and suction. Okay, any questions to there? How do I know the patient needs suctioned? What's that? Crackles? Okay.
Sawtooth on the flow waveform.
Yeah, absolutely. So look at your waveforms on the ventilator perhaps, if they're, right now we're bagging them. So if we're bagging them, what kind of things would we notice when we're bagging?
Higher pressures.
Possible higher pressures, it'll decrease compliance perhaps. Yeah, you may see secretions in the endotracheal tube itself. Yeah, saturations might have dropped a little bit as well before you pre-oxygenated. So there's all kinds of different things that will let you know that that patient needs suctioning.
Would there be a schedule for it as well?
This PRM, so as necessary. Yeah, so there's no schedule for it. It's just every time we're monitoring the patient, that's what we're looking for. Okay, nursing is it's a shared duty. So in the intensive care unit, nursing will be suctioning as well. Okay, so I'm going to open up the peep keep. Okay, and put our suction catheter through. So I'm not applying suction. Okay, try to get it down there as much quickly as possible. Okay, and how far do I go?
The lines match up, like the markings.
Yeah, they might.
Yeah.
I had lines on it. How far am I going to go?
Resistance and pull back a little?
Yeah, you bet. So you're going to hit resistance. If the patient is able to, they'll start to cough as well. Okay. Yeah, pull back just a little bit and then start applying suction. Oh, hello.
Non-stop.
That's new.
Ironically, sometimes that's what it sounds like.
That's right. I said, my God, he's alive.
Didn't we bypass the vocal cords?
I think he's intubated in the right spot. Anyway, so we're going to pull back just a little bit and then we're going to apply suction. Now, there's intermittent suction and then there is just suction, okay? Really, the intermittent suction is just for when the suction catheter is out of the endotracheal tube. So how far is that? I don't know, about that far, okay? So really, intermittent suction is just so that the suction catheter doesn't adhere itself to the side of the bronchial. That's the reason for intermittent suctioning, okay? The rest of the time, it is just continuous, okay? And what I'm doing is I'm just rolling the catheter as I'm bringing it up through the endotracheal tube. Okay, notice I've just captured it so it doesn't go anywhere. Can let go, put the peep keep back on. Give him some more drugs so he stops moaning. Pilot line in his eyeball. Okay, so we reoxygenate the patient. At this point, we can have a look at the secretions. They'd still be in the catheter. And there may be some in the tubing as well, depending on how much there is. What color is it? How much is there? What its viscosity is. Okay. So look at the monitors again. Make sure we haven't put him into some type of braddy or something like that. Look at his stats. Okay. So the time limit for the amount of time between when you actually apply suction to when you get back out again should be 15 seconds. Okay. Shouldn't be down there any longer than that.
Just out of curiosity, pre-oxygenation, are we saying 2 minutes? Because it's not on the checklist, but
Yeah.
2
Usually
minutes?
at least 2 minutes, yeah. Yeah. And in between, about a minute. Yeah. As long as their sats are back up again, that should be sufficient.
So there's not like, it's not like with pre-oxygenating during intubation where it is 3 minutes. It's
Yeah.
kind of like-
And on the ventilators, when you hit pre-oxygenate, it's on for either 1 or 2 minutes, depending on the ventilator. It'll give you 100% oxygen. Okay. Okay, so if these secretions are really, really super thick, we can instill the patient. It's not regular practice at every site, but some places will still be doing it. And all they're gonna do is they're going to take normal saline and inject about 5 cc's of normal saline down the endotracheal tube. Okay. So we would put some down there, and then just keep bagging. Okay, and then we would chase that with the suction catheter. Come on, come on.
Some places actually have policies saying you're not allowed to do it, where you're not allowed to instill, because there have been papers that have suggested it may increase risks of that, but the jury's still out. Some places are still.
Yeah. So it's still in your lab. So practice it. At least you'll know what it is and why you're doing it when you get to your clinical sites, okay? So again, look at your secretions, what do they look like, was it better getting the secretions up? And you would continue suctioning until they sound clear. So you'd be auscultating in between or getting someone to help you by auscultating as well between each pass, okay? Any questions?
What's like the easiest way for like sterility to go wrong?
Letting go of this.
Okay, so you have to
Okay.
hold that the whole time?
Yeah.
And you always have to loop it around?
I loop it around. I find some students hold it here, or if they hold it here, then it's gonna hit something, right?
Okay.
That will keep it safe, so it's not gonna go anywhere. Plus, you can't use this hand for anything else other than holding your catheter. Okay, you won't be, oh, I'm gonna bag the patient now. Okay, so that's usually what happens, it's just where you're holding the catheter.
So this really is a two-person job?
Yeah,
Okay.
yeah, I mean, it's hard to bag and suction
Yeah.
at the same time.
Yeah.
Yeah. Okay, suction trap. So suction traps are for getting a sample of their sputum. So I noticed the sputum is a little yellow. Okay, so we need to get a sputum sample so that we can send it to CNS, send it to the lab for CNS, culture and sensitivity, find out what it is they're growing, and what antibiotics would work for it if it's a bacteria. Okay. So what we do is put the sputum trap in between the